with this objective, the objectives which Sandeepan sir has just mentioned, with which today we see the Society of Eczema Studies being launched, and the first webinar, if you can just see the browse through the topic, it is cyclosporine in dermatology. You would normally expect, I think, the steroids in dermatology is to be the first webinar topic, but we have already said we would like to use less and less steroid, and we would like to use drugs which are more targeted and which are likely to have those advantages, which probably, of course, steroid is not a drug which we are not going to forget, but it definitely has certain reasons why we wouldn't like to use a lot of steroid. So it's my pleasure to be a part of the first webinar of Society for Eczema Studies, and it's my pleasure to welcome all the panelists, Dr. Sandeepan Dar himself, Dr. Raghuveer Banerjee sir, Rajiv Malakar, Dr. Abhishek Dey, and Dr. Maitri Panda. The first webinar has to be very special, and the first question what Dr. Sandeepan sir posed to all of us is why Eczema Society? That's what he asked. And so my question also has to be the same thing. Why cyclosporine? When we have many drugs that, we have corticosteroid, we have immunosuppressants like azathioprine and so on. So why cyclosporine? This is definitely a question I'm sure it ponders in everybody's mind. Sandeepan sir, you could first take up this question so that others can also add up to the question. Yes, sir.
Yes. Why cyclosporine? Manjunath, the reason being, I have been using all these things, all the molecules you have mentioned, like steroids, azathioprine, mycophenolate, mofetil, and others. But I must say that most consistent adverse effect wise list, provided proper monitoring is done, patient selection is proper, most consistent result, quick result, and free of adverse effect is seen with one single molecule, that is cyclosporine, in a host of conditions where nothing else really bring the disease under control, be it severe atopic dermatitis, be it severe psoriasis or psoriasis in upswing, be it chronic urticaria. So steroid can be given up to certain period, but beyond that, it develops a lot of adverse effects. Cyclosporine you can continue for many months, in fact, rotationally for many years. We will be coming to that in more detail. I must say one single line, that most effective, most consistent, only, I often tell this in my lectures, the only, side effect of cyclosporine is the cost. There is no other side effect, practically. This is not because this, this is the platform of biologics. I have been writing cyclosporine for last 20 years. In fact, that time the cyclosporine was someone else's, and that was still my favorite molecule.
Thank you so much, sir. I think you have summarized almost everything. I wish all of us, all of our panelists, add something. Dr. Rajiv, sir, would you add something, or what is your take on cyclosporine?
Yes. Am I audible?
Yes.
What Dr. Dhar has said is absolutely correct, but I'd like to summarize it even further. There are three basic points which helps cyclosporine to be the drug of choice in these circumstances as compared to the other. Number one, it is not a cytotoxic molecule. Number two, it doesn't cause immunosuppression. It doesn't cause significant bone marrow suppression, rather. And which the third point, which may not be relevant in pediatric age group, but is relevant in the adult age group, it is not teratogenic.
Thank you so much. Raghuveer sir, your take.
Yeah, they have summarized almost everything. So what I would like to mention further is we are going through the COVID times, and cyclosporine is definitely approved in this scenario. Especially in the COVID scenario, there is no problem in giving cyclosporine. And secondly, the monitoring is not so stringent like with azathioprine and all. As Rajiv has already mentioned, the significant amount of myelosuppression can occur even if with proper monitoring. But with cyclosporine, we have found the safety profile of the molecule is very good. And in children, we have hardly seen any side effects, neither hypertension nor nephrotoxicity. As Dr. Sandeepan sir has already mentioned, he has used this molecule extensively. And I agree with sir that we have not seen much of a side effect with the molecule.
Yeah, that's a very practical point you have mentioned that, regarding the monitoring part. Dr. Abhishek, what is your take? Anything you would like to add? I know
Sir,
it's getting more
what-
difficult for you, the people who are going to answer this question.
Sir,
finally.
I think everything has been summed up, but there are another important issue is fast onset of action, which is also sometimes important. Suppose we are giving antihistamines for the chronic spontaneous urticaria, it will take some weeks to show good control of the disease. But during that period of time, we can give it. Or some religious festival is coming, the patient wants a quick relief. Methotrexate may take about 12 weeks time to start action or 10 weeks time to start action. Cyclosporine always give a very consistent result. It's a fast result. It's not immunosuppressive as such. And side effect, I would say there are side effects, but the side effects are easy to monitor and easy to control. And we feel with cyclosporine we are in the control of the disease. We are control of the drugs much more than many other immunosuppressives.
Yeah, thank you. I think you have a very important point. You have mentioned that it acts on, even when we understand the molecular mechanism, it acts at the early phase of the immune response. So that's when the T cell receptor activation takes place. That's one of the reasons why it acts so quickly and consistently. That's something. Madam Maitri, I'm pretty sure you'll have something to add upon.
I have nothing else, only that the patients are always happy when they are on cyclosporine.
Okay, so yes, I think we have had a wonderful discussion on indeed. Yeah, yes.
Another thing that it can be easily given to children. For many other immunosuppressants, we cannot give it in children. That is another important issue.
True. Yeah. So it has, although guidelines may be different, but the practical experience, which what Dr. Sandeepan sir or Dr. Kobir sir, Dr. Rajiv, everyone has shared, it's wonderful to prescribe a cyclosporine than many other immunosuppressants, because cyclosporine is potent, but it is non-cytotoxic. That is something which we should understand. It is not a cytotoxic drug. It's an non-cytotoxic immunosuppressive. In other words, it's an immunomodulant. So that's something which we all should understand. So once a drug is non-cytotoxic, which Dr. Rajiv just mentioned, the bone marrow suppression is less likely and almost nil. That's something it is dreaded. Even today, I have just seen a patient who took methotrexate 6 tablets continuously because of misunderstanding. And she's admitted with severe oral ulceration. So you are quite unlikely to experience such stages. That's because it's not an immune suppressant. It's a non-cytotoxic immunosuppressant. In other words, it's an immunomodulant drug. So I think this particular question I specifically posed because people should get an overall idea about what cyclosporine, especially for those who, I'm sure all of you prescribe cyclosporine, but probably not as frequently as perhaps with other immunosuppressant drugs like many others which I have mentioned. Now, obviously, I always felt cyclosporine can be used everywhere where steroid can be used. It's my general belief. And cyclosporine also can be used where steroid cannot be used. Best example is psoriasis. So it's something I would put it that way, but I think it's better to hear from Madam Maitri. This time it is going to be ladies first for you. So you could tell the approved indication.
Atopic dermatitis and psoriasis. So apart from that, sir, there are many unlimited dermatitis where we can prescribe. Like your question follows off-label indications.
Yes.
So, sir, like you said, everything and anything we can put the patient on cyclosporine starting from infant to adults. So, sir, my take would be I prefer in first-line drug in many conditions like chronic spontaneous urticaria, like SJSTN patients, pyoderma gangrenosum, like even oral lichen planus, sir, I am prescribing regularly and getting a very good result as compared to oral steroids. Apart from that, sir, you have put in the indications and old indications like alopecia areata, autoimmune disorders. So the list is endless, sir, but truly speaking, sir, this drug is very, very effective And what I see usually is the patients revert back with a very positive response. They are very happy initially when you put them on a proper dosing of cyclosporine. So that is my
Yeah.
take, sir.
You mentioned 2 points. Number one is, what are the approved indication, atopic dermatitis and psoriasis. Now, I would like to ask from the panelists, since you have already, I think, more or less covered most of the indications, what is your favorite, other than, of course, we all use it in psoriasis and atopic dermatitis. Rajiv said, what is your favorite indication apart from atopic dermatitis with psoriasis? Where do you think it consistently works? Yeah.
Yeah, in my experience, what I found, this to be very consistently working, that is in lichen planus number 1. Number 2, I have found it to be very consistently to work in severe drug reactions like SJS and TEN. That has become sort of my to-go drug when the person presenting with this severe condition. And I have also been consistently getting results in cases of chronic idiopathic urticaria.
I think you mentioned very important indications, especially SJSTN, wherein now the think tank is almost shifting towards the usage of the cyclosporine. Considering the seriousness of the illness, nobody will think about the cost of cyclosporine, at least in this condition. And it's not a very long-term usage as well. So considering that, I think SJSTN definitely take an urticaria, especially for people, they don't want to take steroid. Even we don't want to give steroid. So cyclosporine will be very important. Raghuveer sir, would you like to add some more in addition to,
Rajiv has,
off-label.
Okay. Rajiv has mentioned most of them. Apart from that, I have tried it for alopecia areata also. The relapse rate is high, but it works very well. So where we are not willing to give a steroid or something like that, so in those cases, cyclosporine, of course, tofacitinib and all have come up now, but with cyclosporine, we have found good results with alopecia.
I think we have, wonderfully mentioned. Anybody has used in pyoderma gangrenosum? That's yet another indication. I felt it works
Sir,
well.
I have been using consistently in pyoderma gangrenosum. In fact, I use tacrolimus topically and oral cyclosporine, and I find good result with that. I think it's better than any other medicines you have used beforehand. So that's another indication is quite, offbeat. I don't think that too much of literature mention is there, but I find very consistent is lichen planus pigmentosus. I mean, this is something I don't think it's mentioned too much in the literature, but it's better than steroids. If you give 3 to 4 months, almost always lichen planus pigmentosus, at least the disease halts, and then you can carry on with the other processes, to remove the pigment.
Yeah, I think you have added those, some of the couple of indications. Any panelist, Sandeepan sir, you have anything apart from these, especially in pediatric age group that
yes,
we like to? Yes, sir.
Yeah, Manjunath, I must say that, 5 primary indications of cyclosporine for which I use in my practice. Number 1 is atopic dermatitis. Number 2 is psoriasis. Number 3 is lichen planus. Number 4 is multiple patches of alopecia areata, which cannot be controlled with topical steroid or short courses of oral steroid. And number 5 is chronic, autoimmune urticaria. These are the 5 indications. But other indications where I have used cyclosporine, or where rather I have shifted to cyclosporine, as you said, pyoderma gangrenosum, very rightly, I have given couple of patients of pyoderma gangrenosum cyclosporine because that can be given for long-term purpose. Steroid cannot be given. Clofazimine, as we used to believe, does not work that well. But other conditions, let me tell here, as Rajiv very rightly pointed out, for SJS, TN, I prefer cyclosporine short course rather than oral steroid or IVIG. Next. I often see quite a good number of cases in our Institute of Child Health, me, Raghuveer and Rajiv, we see quite a good number of cases of, diffuse cutaneous mastocytosis. And it is extremely difficult to control their flare of itching and development of diarrhea sign with just antihistamines. That is a practical issue. Theoretically, anything may be written. So everything can be done with antihistamine. Nothing. In practice is a different ball game. Where you are inside the clinic, then you face the music with your patient. Then your knowledge of interleukin and other thing, patient is not going to buy. They will say, doctor साहब फायदा कहाँ हो रहा है मेरा बच्चे को? Where is the result? So I have started giving them cyclosporine for diffuse cutaneous mastocytosis. I have given cyclosporine for extensive, recalcitrant papular urticaria, which is not responding, and children are absolutely, their life is hell. Parents are totally distressed with the severity of itching and the severity of disfigurement of papular urticaria, and a number of other conditions in collagen vascular diseases, all as an immunomodulator. Bullous diseases in pemphigus, I have gradually shifted from other immunosuppressant to cyclosporine, those who can afford. And by and large, let me tell you, people can afford for cyclosporine because their quality of life comes back to to normal to a great extent, as Abhishek said, that the onset of action is very fast. That is another advantage of cyclosporine.
I think we have wonderfully summarized majority of the indication. Anybody, any other indications? Would anybody,
Sir,
any panelist would like to?
Sir, another, obit indication I'm saying, because others are already mentioned, you also showed, is a type 2 lepra reaction. I know it's not kind of, it's not very textbook, but TNF-alpha blockers, if the patient can afford, or cyclosporine, actually gives very good result. It's, even though it's thalidomide in the textbook, and so many times thalidomide is so difficult to give to patients. So it works in the type 2 lepra reaction also.
Yeah, I think it's been a wonderful summary for all the viewers of today's where all you can use it, and why it is justified to use cyclosporine also. In the coming part of the webinar, we are also going to discuss that. Couple of other indications I just thought where I have not used, but as I was preparing for, I got to know that you can use it in discoid lupus erythematosus, yet another condition where it has got Sandeepan just mentioned about collagen vascular, where discoid lupus, which often comes and disfigures, it causes destruction of the hair. If it involves the scalp, it's going to cause the hair loss, which is permanent, and cicatricial alopecia, which can be prevented if diagnosed early, treated early. That's one condition. And other important condition which we don't handle day to day is graft versus host disease, which is something like lichen planus. The chronic graft versus host disease. It's something like a severe form of lichen planus. These are the two conditions. If you are in a setup of hematology, where you get to see this chronic graft versus host disease, you can consider this drug in addition to what is already discussed. I think we will have to move because we have many more questions. A lot of questions have come across from the people who are likely to watch and who are watching this webinar. It's important for all of us. We just mentioned that the investigation or monitoring may not be great with cyclosporine as compared to, say, methotrexate or azathioprine. Dr. Maitri, madam, could you please quickly tell us about what investigation would you like to do prior to cyclosporine installation?
Specific, definitely for the renal function test, liver function test, and the CBC. Even though it has least effect on the hematopoietic system, the workup of baseline CBC is a must, sir. And active infection should be ruled out if there is some suspicion like the hepatitis B, C, and HIV. So these are my regular investigations. So their list is endless. I do not do the metabolic parameters regularly. Blood pressure check, that is again important. Otherwise, sir, for the routine workup of tuberculosis and all, I don't do it regularly.
Yeah, now this question has to be to Dr. Raghubir Banerjee, sir. I'm sure you prescribe it in day-to-day in practice. Apart from what she mentioned, she said she wouldn't do the metabolic the thing. Would you agree, or you have some take regarding?
I agree with her. I agree with her. No, nothing much is necessary in our day-to-day practice, but serum electrolytes. This is something we should keep in mind when we are planning for long-term cyclosporine. If it is within 3 to 4 months, it's fine, but beyond 4 to 5 months, like the hyperkalemia, hypomagnesemia, hyperuricemia, these issues might come in. So if you're planning long-term, I think we can add monitoring of the serum electrolytes. Not very often, maybe in 2 or 3 months, we can have a check. So that is something I'd like to add. Otherwise, she's mentioned the routine testing.
Yeah.
Sir, I think
Yes.
at least a baseline fasting lipid profile I always do because many times it will be surprising. So many patients, even the patient never knew that they'll come out a baseline lipid profile which is quite altered. So that's why uh, whatever the textbook says, basically I do 4 or 5 tests on a CBC to rule out any infective etiology. I usually do an LFT and creatinine. I do a lipid profile, and I tend to do a quantify and TB gold test. However, Sandipanda has discouraged me just yesterday, so I'll possibly stop doing this excessive investigation from now.
I think you did throw a very relevant point because cyclosporine among those drugs which can cause dyslipidemia, especially if the patient is already on steroid, especially for those patients who are already on steroid, you're tapering and you're trying to give cyclosporine in such patients because both these drugs can disturb the lipid profile or conditions where acitretin the patient has received, which also can disturb the lipid profile. I think it's very relevant to what important point you mentioned. Rajiv sir, you will take anything extra you would like to do or you would like to add something?
There's nothing to add much to that. Everything has been said, but I am quite conservative in my approach, and I tend to follow the guidelines that has been laid down in the textbook. I do specifically do the serum electrolyte. See, I specifically do the serum creatinine, blood urea, nitrogen, and urine analysis at the very beginning, which is followed by CBC, LFT, which is followed by lipid profile, and also I do magnesium and potassium and uric acid. I do it just before starting medication, then every 2 weeks for the first 1 to 2 months, then every monthly. And I also do this along with blood pressure monitoring at least twice weekly. I follow this very rigidly.
I think Sandeepan sir, we need your intervention here. You have to draw somewhere. You have a person who is a strict follower of the guidelines, and Dr. Maitri says, I am not so fond of giving investigation. I think your intervention is needed here.
Basically, as Abhishek said, in our West Bengal State QTCon, which was a physical meeting after 2 years, just the day before yesterday, I spoke on cyclosporine for 30 minutes. So that's what he was referring to. So one of my slide was what are the baseline investigations you should do. It is CBC, LFT, then urea creatinine, and electrolytes when long term, as Raghuveer has said. Here I shall come a bit more about electrolytes and urea creatinine at an interval, and chest X-ray, as Abhishek said. I do not do it unless and until the patient has telltale evidence of pulmonary tuberculosis, or the close family members who stay in the same house have open pulmonary tuberculosis, or the patient gives a history of previous pulmonary coughs which has healed, then only the question of doing a chest X-ray comes. So otherwise, we should not exhaust the investigations too much. Now coming to electrolyte, by and large, the dose of cyclosporine what we give for dermatological indications, see, it varies from 2.5 to 5 milligram. Although I have given 6 to 7 milligram per kg per day also in some very severe recalcitrant atopic dermatitis or psoriasis. At this dosage, electrolyte imbalance does not by and large occur in more than 95% of the patients. The second question is, there is a lot of hype about the hypomagnesemia. I'll request all our colleagues who have joined over here, please go back and see that this hypomagnesemia mostly been reported in the oncology journal or rheumatology journal or transplant journal, because this hypomagnesemia is because of the cyclosporine dose, which is at least 4 times, if not more, the dose of dermatological indications. There the electrolytic changes, hypomagnesemia, and all these things appear. Once upon a time, I was very much interested in all these things because of some discussion. Then I went back and I searched and I found all this literature are actually oncology, rheumatology, or transplant journals. So in dermatology journal, there is hardly any mention hypomagnesemia. Occasionally, yes, I must say that occasionally 1 or 2 patients out of maybe few thousands of patients for various indications have given cyclosporine, have complained of little bit of tremor, and magnesium level has come little bit low. But that was a very transient phenomena, and we had to, stop cyclosporine or reduce the dose of cyclosporine there.
I think you have nicely summarized, and you have also given your verdict where you need to do and those investigations which we don't routinely do. I think you have told very important thing about tuberculosis, which is quite common in India. I think in you have a patient whose vicinity has a tuberculosis. Probably there you need to do chest X-ray, probably interferon gamma release assay or something like that. At the same time, a patient who you suspect probably an immunosuppressed patient due to HIV infection. In such patients, maybe HIV serology, hepatitis B, those kind of things. In other words, we need to thoroughly evaluate a patient clinically and do the baseline investigation, which is already been mentioned, and additional investigations. Everything depends on how a patient outlook is. Based on that, you can add those investigations. Dr. Abhishek, you wanted to say something, I think.
Sir, I think what we need, sir, one Indian sort of guidelines, because
Exactly.
as Ajib sir says, mostly there is an issue. We all know possibly this doesn't get altered in our routine practice, but we need some sort of guidelines to save ourselves in legal scenario. So this is something is grossly missing in India.
Exactly.
Sandeepan sir, will that be one of the objectives of SES now?
Yeah, you have just read my mind, Manjunath. I was going to tell that these are the need gap. Actually, we have realized that there are so much of need gaps in atopic dermatitis, because whenever I talk at the international platform, immediately the question comes, where is the published data? In global scenario, without published data at hand, you cannot say anything, and nobody is going to accept that. So we need to have published data, we need to have registry, we need to have our own guidelines, and that is the motto of SES, right? And that is one of the mottos of SES.
Yeah, otherwise we are likely to follow other guidelines. For example, of course, those guidelines are definitely good, but only thing is we need a tailor-made to our patients. I think that's exactly we need to do. And sir, you can stay with my next question, Sandeepan sir. How frequently we need to do investigation, and in case if there is some abnormality, for example, a slightly deranged urea or creatinine, should we withhold, or should we give cyclosporine at all?
Okay. So, as you have told Manjunath very rightly at the beginning, there are certain baseline investigations which you should do for all patients. Then there are certain additional investigations which you should customize for a sector of high-risk group of patients, right? They are not to be done in all patients. So when I see a patient on the first day, say for example, and I do the baseline, and I see the baseline urea creatinine is high, but the patient is still cyclosporine, I give cyclosporine. I don't stop cyclosporine. I give cyclosporine. Maybe slightly less dose than usual dose I give, 4 to 5 milligram for psoriasis or atopic dermatitis. Then I'll do the retesting after 2 to 3 weeks for CBC urea creatinine. By and large, in my practice, let me tell you, initially for a fresh patient, I do once with all the parameters normal, once a month CBC urea creatinine, and as Abhishek said, only baseline, first time lipid profile. And if I see next the lipid profile is normal, I don't repeat it for next 5 to 6 months, right? And when I see that urea creatinine is increased, I monitor them. I don't press the panic button, because the patients, or in my case, where pediatric patients are mostly, I see the parents, they are often anxious about it. I have to do little bit of counseling, and I have seen over a period of time, I tell them that this is for 3 to 4 months or 5 months maximum, and after we stop cyclosporine, then gradually things will subside.
I think you have nicely told. I think the message is very clear that it's not necessary that we should totally abandon this drug just because there is some abnormality in the renal function. we can always, if needed, discuss with a nephrologist, and then as needed, the dosage can be adjusted. And the one thing why the name of nephrologist I took, they have used these drugs lot in the past. Now, of course, the cyclosporine is literally being replaced by the other drugs like tacrolimus. Tacrolimus. So now the cyclosporine has come to us. Indeed, I think we are the bigger prescriber for cyclosporine than nephrologist. Probably nephrologist prescription on cyclosporine I see when the young lady who has undergone transplant and she's planning to conceive. That is when you see the tacrolimus being shifted to cyclosporine, and mycophenolate gets shifted to azathioprine. That's something phenomena which I see in many of our patients. Otherwise, I think one more point which I would call Rajiv sir to give you. Do you take the history of, when you say a subset of patients who have tailor-made indication, do we see a patient who is already on a nephrotoxic drug? Do you think we need to differ them on cyclosporine, especially people who have habitual takers of NSAIDs? Rajiv sir, this question to you.
Of course, the close monitoring is absolutely essential in those cases because it is a very obvious known adverse. It is mentioned specifically in our textbook to be an important drug interaction because there is a compounding of the toxicities. It is not only about cyclosporine. In any treatment, whenever you are using a medication whose potential adverse effects can be compounded by the concurrent medication, you have to be very careful. Either you monitor the patient much more closely, or you switch to some other medication which doesn't have the same potential adverse effects. So,
well said.
In these patients, they will be again exactly like what Dr. Shandipan Dhar has said. You need to monitor these patients very carefully.
Raghavi sir, I'm sure you will have something to advise on the question that we just dealt with.
Yes, one comment I'd like to make. Till date, in all the literature where cyclosporine has been used for different dermatological conditions, there is no report of renal failure or renal fibrosis. So that nephrotoxicity part is taken care of. In all the studies where they are given long term for 2 years, there is no single report where they had shown there is some significant renal failure, nephrotoxicity, renal fibrosis. So that way, it's a very, very safe drug. Even again establishing the safety. And regarding what you have raised the question about combining with a nephrotoxic drug, I agree with Rajiv that in that case, a closer monitoring is necessary. And maybe we can start with a lower dose.
Yeah, I think the other question automatically comes. I'm sure this question would be pondering in the mind of viewers. A patient who is hypertensive. Now, you are in pediatric institution. You probably don't get to see so many patients on hypertension. Yes. So I think I should direct this question to Dr. Abhishek Dey. What would you say if a patient is already hypertensive, but you see there is a definite indication for cyclosporine? What is your take? And Dr. Maitre, you can also give your chip. You can chip in your advice later.
So best thing about this hypertension and nephrotoxicity, both these are mostly dose-dependent side effects. So if I know a patient who is hypertensive, of course, and under treatment and well controlled, of course, I'll do at least 2 baseline check of hypertension and then start the treatment. But at the same time, we will have to keep a more regular check for those patients. If we think the patient's blood is not well maintained, blood pressure is not well maintained below 140/90, then at times we either may have to adjust the dose of the hypertensives, or we can also reduce the dose on such patient of cyclosporine. But rarely we require a situation where we cannot give cyclosporine in a patient of hypertension. We always have to treat the patient well, and along with we can give cyclosporine.
I think you have mentioned very important thing. The cyclosporine per se, what hypertension it induces is a dose dependent. You're probably not going to come across the cyclosporine related hypertension in the initial period, maybe 6 months or 9 months or up to 1 year. And in dermatology, we rarely go beyond 1 year. So I think we give a holiday, we do a sequential therapy, something we do. So probably that question doesn't come. But those patients who get that hypertension in the beginning phase, probably it's not related to cyclosporine. It may be the transient cyclosporine, which may be related to various factors, which needs to be evaluated by a physician or a cardiologist or respective. I don't think we should just withdraw the drug or stop the drug for that purpose. Dr. Maitri, you have anything to add on just discussed question? The patient is already hypertensive. Will you give
Yes,
or will you defer it?
I'll rather prefer a pulse dose of cyclosporine, sir. Wherever I see the hypertension, antihypertensives, the patient is on 2 or 3 antihypertensives, and I would prefer a pulse dose or a combinational therapy. So, sir, rather combining 2 immunomodulators will solve my patient treatment, and otherwise, sir, I prefer pulse therapy, weekend therapy like oral mini pulse. I am prescribing cyclosporine and pulse therapy. So that also, sir, I have seen that regular monitoring of BP in comparison to the daily dose of oral cyclosporine, in pulse therapy, I have seen the BP is better controlled. So, sir, my take would be 4 milligram per kg body weight or still higher dose, but weekend therapy. The response is quite good, sir. I have not seen any patient not responding, and maybe an additional safer molecule like apremilast or retinoids to add up to the condition, treating condition.
Yeah, it's well said. Sandeepan sir, do you recommend this pulse therapy, or is it still a topic of debate, or it can still be used?
Right. Manjunath, before that, I must say a few words about
Yes,
cyclosporine and hypertension issue.
yeah.
No,
Right,
let me start with a very small story. Many of my adult patients, they came to me saying that, doctor, you have given this drug and my physician has said that you cannot take this drug because your pressure is very high. Then I tell them that, see, I can, for your condition, there is no other drug which can be given. So the drug cannot be changed, but the doctor can be changed. You change your doctor. So I am giving you a reference of a doctor. Immediately I call my cardiologist friend, who is a DM cardiology from PGI Chandigarh. I tell him in front of the patient, a patient को ये problem है, blood pressure है, cyclosporine मेरे को देना है, अभी 6 महीना देना है, will you be able to bring down? He said, ये तो चुटकी की बात है, कुछ भी नहीं है. Don't worry, we have got hundreds of antihypertensive, which can bring down the. So that is the thing you have to very boldly tell the patients. So, you have to go to a proper physician who knows how to tackle the hypertension in a patient who is receiving cyclosporine. I often given an example to my juniors. I say a patient of pemphigus vulgaris who needs very high dose of steroid, having tubercular meningitis, will you stop steroid in that patient and let him die because of now rituximab is available? But I'm talking about the story. This we used to often debate in PGI Chandigarh 30 years ago. So there is nothing, no absolute contraindication for cyclosporine. All are relative contraindication, and they have to take a proper, guidance from a proper doctor. So this is number one. And number two is that weekend, cyclosporine therapy. Yes, I advocate weekend cyclosporine. That is one of the modality I often give. When the disease is under good control, then for 2 consecutive days weekend cyclosporine, we have seen that there is good maintenance of the treatment. There are 3 advantages of these. As Maitri said, I agree with her. One is the less cost, second is the less side effect, and third is the patient compliance is also good because of the less cost, right? So if it is giving result, why not?
Yes, Dr. Manjunath, can I make a comment?
Yes, sir, please.
Yeah, there are 2 drugs, calcium channel blockers, diltiazem and verapamil. They are found to be inhibitors of the cytochrome P450 in the liver, and they increase the level of the cyclosporine. So if the patients are on these 2 drugs, then I think we need to change the molecules because they have significant drug interaction with the cyclosporine as antihypertensive.
I think,
and just one more word,
Yes,
Manjunath.
Yes,
I think there are situations or territories where I think we as dermatologists should not try to trespass. Suppose, treatment of urticaria in a pregnant lady. We should always be done in consultation with an obstetrician. Similarly,
Yes.
cyclosporine in the hypertension issue, we are not the expert of hypertension, and why to take the responsibility on our shoulder? This is a big medical legal responsibility. So always collaborate with your physician or cardiologist colleague and jointly give treatment. Then patient also gets the best response, and you also save your own skin, not only the patient's skin.
And apart from what we just discussed, I think a couple of things which I come across, some of the chat verdicts from some of our learned audiences, even lichen planopilaris responds well inside. That's what Dr. Jatin Sharma says. And one important message I got from Dr. Prabhakar Sangoli, who is very active academician as well as who loves to be a wonderful clinical dermatologist, is that strong lordosis association with cyclosporine. So that is also reported. And probably he says baseline urine and stool examinations. Very much Mr. Sandeepan sir, in one word, in every patient, strong lordosis, and it's probably anecdotal occurrence. Probably in suspected cases, yes, probably urine and stool examination. Yeah, I think. And how about extrapulmonary tuberculosis? Should it be ruled out before cyclosporine?
Right.
Sandeepan sir.
Yes, Manjunath, I shall address these two questions. Of course, Dr. Prabhakar Sangoli is a very respected academician. Thanks, Dr. Sangoli, for being over here and giving your very erudite input. Yes, there are occasional reports of strongyloidosis with not only cyclosporine but also with dupilumab, right? So, but these are on only few cases, anecdotal cases. It is not a routine examination. Unless and until there is strong clinical suspicion, there is no need. If there is a pre-existing renal compromise, you do urine test. If there is a history of strongyloidosis earlier, or any worm infestation earlier, or you are suspecting it because patient complains of repeated pain abdomen, then only you do these things in selected patients, but not routine. As far as the extrapulmonary tuberculosis is considered, I saw Dr. Nivedita Patro. She is from also from Bhubaneswar, I understand. She is also an academician, very good academician. My take on this is that, Nivedita, we cannot go and rule out each and everything for giving cyclosporine. It is only to be tailor-made as the clinical situation will demand. So that is the clinical medicine actually. So otherwise we will totally depend on investigations, and we will do a host of 100 and 120 tests to rule out each and everything. We cannot do that. If there is a strong suggestion of extrapulmonary tuberculosis, whether the patient is regularly getting for last 2 to 3 months fever, there is some abdominal mass, or anywhere else you have done ultrasonography or MRI. So in such situation, you should go for more aggressive investigation. Otherwise, routinely it is not needed, because tuberculosis by and large, as contrary to many of the biologics, is not an issue for cyclosporine. That is another advantage of cyclosporine over biologics.
Wonderfully said, sir. I think that has answered many questions which I see them in chat box as well. Now, this question is to Dr. Kubir Banerjee, because you have seen a lot of patients on cyclosporine and for a long time as well. How common cyclosporine-induced gamma hypertrophy and hypertrichosis, hirsutism? How frequently you see them? This is from Gaurav Dash. He's also from Bhubaneswar.
We have seen quite a few patients, gum hypertrophy and hypertrichosis, but usually it's not a major problem because hypertrichosis slowly goes away, and with good dental hygiene, even the gum hypertrophy can be taken care of. But we were discussing so much of renal and all these things. So instead of that, these are the conditions or mucocutaneous side effects that we have seen quite commonly in our patients. The hypertrichosis and the gamma hypertrophy. We have come across many patients.
Can I come over here, Manjunath?
Yes, sir. Yes, sir. Please. Yes, sir.
As far as the hypertrichosis is concerned, it is 100%. When cyclosporine is given between 4 to 6 months at a stage, it is seen in 100% patients. It is only the intensity of hypertrichosis or how much it is cosmetically acceptable. But by and large, within next 9 to 12 months, once the cyclosporine is stopped, they disappear on their own to a great extent, more than 90%. So counseling is very, very important.
Yes.
Now, the gum hypertrophy, it is not very common. We have seen few cases, me, Raghuveer, Rajiv, but only it occurs only when patients start abusing cyclosporine, self-medication. And another important precipitating factors for gum hypertrophy is the bad orodental hygiene that precipitates gum hypertrophy. And this I have repeatedly shown in my presentations that how bad orodental hygiene precipitates gum hypertrophy, and because of self-medication or self-abuse of cyclosporine.
Yes, sir. I think that's something which very frequently asked in the Viva questions regarding these are the adverse effects of cyclosporine. Cyclosporine is one drug where all other immunosuppressants, they make one lose hair, but this is one drug which makes hair grow. So that's how this drug is different than others. Rajiv sir, is there any concern related to infertility when the male patient taking? Will there be effect on the sperm motility? This question is from Dr. Binsi, who's from CMC Vellore. Thank you, madam, for asking this question. I think very valid question. Anything to say, or any panelist? Rajiv sir, this question to you.
I'm sorry, but I haven't come across this condition when using cyclosporine. Primarily, we use cyclosporine, but in our practice, most of the pediatric patients, this concern doesn't come at all.
Doesn't come,
But,
I understand that.
at all. But
Dr. Maitri, yes, sir. Yes, please
fine,
complete, sir.
but
Yeah,
even
Maitri,
in adults,
anything
I
you have
haven't
an
come
idea
across.
about this? To me, cyclosporine is not a cytotoxic drug. Probably that concern may not be major. So, any take on this, Dr. Maitri?
As per, if you take it a very long dose, sir, there are very scattered reports of there is, I think, very few reports on this infertility. But, sir, that again may be due to the long-term use, which can lead to a vasoconstrictive effect. Sir, maybe because of that, there may be a temporary reduction in the sperm count. But otherwise, sir, by the mechanism of action, this cyclosporine is not at all cytotoxic. So, sir, the sperm manufacturing, there may not be any problem, sir. So, I
Yes, I
think
think,
there are one or two reports, sir. They are case reports. Maybe
Yeah.
ma'am was speaking about that.
Okay. Yeah, wonderful. I think you have summarized. I think maybe it's not a major concern, but still, in a patient, if we have a patient who is likely to father a child, and in such cases, probably we may have to explain. There are rare reports. I think otherwise there is no major concern. Now I have to move towards, because we are running short of time. So obviously our movement has to towards two important diseases. One is psoriasis, other one atopic dermatitis. We'll quickly go through. Now this question, I think we'll get kind of very brief answers so that the questions can move quickly. Cyclosporine in psoriasis, step up therapy or step down therapy, Dr. Abhishek?
Step down, sir, because I want a quicker control with the disease.
Yeah,
Both in
hit
atopic
hard.
dermatitis, severe atopic dermatitis, and severe
Yeah, I can say
severe,
Sandeepan sir also nodding
psoriasis.
his head. Still hit hard.
Agreed.
Hit hard. Yeah.
Agreed.
Hit hard and then you bring it down. That is better. And I think why? Because you are going to capture a disease and then you are. That would be the answer. I think I'll move because a lot of questions are there on psoriasis. Will it work in other than chronic plaque type of psoriasis, Dr. Maitri? What other forms of psoriasis you think it works, or if you have used it already?
Everything, sir, erythrodermic psoriasis. So wherever biologics cannot be given to a patient, I think all the psoriasis I have got results, even including nail psoriasis, scalp psoriasis, flexural psoriasis. And sir, erythrodermic unstable psoriasis, it works the best. So my
Raghuveer sir, Raghuveer sir, you do get to see this palmoplantar pustulosis, sometimes acrodermatitis, continuum of halopo. Have you tried in those patients and you got results?
Yeah, I've
That
tried
can
in a
occur
few
in children.
patients. Yes, it occurs very well. It acts very well, especially in case of palmoplantar pustulosis.
Yes.
And it
Sir,
works for all forms of psoriasis.
Sandeepan sir, nutshell, pediatric psoriasis and cyclosporine.
Right. Pediatric psoriasis is cyclosporine again for acute, flare or psoriasis or upswing. I shall always, I would like to always give this step down therapy to bring the disease under control fast. Here I must say the very basic idea of giving such a costly and super potent molecule is to get the best result in the least possible time. So why should we waste our best arsenal just by giving a homeopathic dose and gradually building the dose? The entire idea of cyclosporine is then lost, right? We must understand that. So we must hit hard and hit fast. These are the two words which are used by the rheumatologist for giving any immunosuppressive, right? So I give them a high dose of cyclosporine for psoriasis. I have seen that psoriasis patients require slightly lesser dose of cyclosporine than atopic dermatitis, same age group, but by and large 4 to 5 milligram per kg per day. And then I control the disease, bring down the disease, then I give it for 3 to 4 months or maximum 6 months. But I always do one thing, and I always tell the parents, this is my pre-treatment counseling, that be prepared for next 5, 6 or even 8 to 10 years of cyclosporine therapy. Initially your child may need 5 to 6 months, maybe next year he may need, or he or she may need 2 to 3 months or 4 months. Gradually the child will need less of cyclosporine. So I prime them for a long-term treatment plan so that they can mentally make up their mind, as well as they can prepare their budget. So this is very important for cyclosporine treatment.
Yeah. I think it covers how exactly you manage pediatric psoriasis. Rajib sir, what is your average duration of treatment with cyclosporine in pediatric psoriasis or otherwise?
Generally for approximately for 6 months. I generally prefer to continue at approximately for 6 months, because following the standardized protocol, you need to continue the controlling dose at least for 2 to 3 months. After that, you have to gradually taper the dose. So it generally takes 6 months to completely cover the whole course.
But we do get to see a quick response, literally PASI going down from, you see PASI 90 sometimes when you start with cyclosporine. You really get to see really good results. Dr. Maitri, do you frequently see, when you try to reduce the dose, the flares occur with cyclosporine?
Basically, I see more with case of atopic dermatitis, sir, because of other reasons. But for psoriasis, sir, I usually, by the time I am stopping cyclosporine, the patient is definitely on some other drug, sir. I don't usually stop and without any immunomodulator. Especially, I give these days, sir, apremilast, a lot of apremilast. So, sir, in my practice, I'm very safe about all that. I keep all systems ready that the patient do not have much flares. Otherwise, sir, with atopic, definitely I see a lot of flares while reducing the dose.
We'll come to atopy a little while later. Dr. Abhishek, do you combine it with methotrexate or acitretin?
With methotrexate almost always, because when I start tapering the drug, I need to continue with some other drug. So what I do, I usually do it methotrexate. If sometimes I can do it apremilast also, but do remember that apremilast has also renal clearance. So we need to be a little careful while combining cyclosporine with apremilast. Otherwise, this is my to-go drug. Acitretin I comparatively use less in this sort of indications. So I cannot comment on that.
Can I make a comment here?
Yes, sir. Yes, sir. Yes, sir. Please, sir.
So there was a very interesting, observation made by Dr. Prabhakar Sangoli sir again, that amlodipine and nifedipine in combination with cyclosporine is more likely to produce gum hyperplasia. I want to clarify here that the pathogenesis of gum hyperplasia, if we go into that the molecular level, it is the calcium channel blocker action. And there is growth of fibroblast in the gum because of calcium channel blocking. So any antihypertensive which works through calcium channel blocking action, whether it is any antihypertensive, say amlodipine or nifedipine, can themselves produce gum hypertrophy. I have found out from my cardiologist colleagues, they have seen a couple of patients with amlodipine only or nifedipine only producing gum hyperplasia. This is something not unknown to them. It is not the combination. They themselves produce, gum hyperplasia. So gum hyperplasia is not a monopoly of cyclosporine. We know it is classically seen with phenytoin sodium, and it is also seen with calcium channel blockers, antihypertensives.
Yeah, I think you answered that question. And a couple of comments on, can it be used in vitiligo, Raghubir sir? Cyclosporine, just to complete it. This is from Dr. Janak Thakkar.
I have no personal experience. Sir.
Yeah, probably not a favored drug. I am not sure.
Yeah, I've
Anybody in the
used
panel has used it?
methotrexate, azathioprine, steroids.
Yeah,
And
and
one more
other
thing, Dr. Manjunath. Yeah.
yeah.
Can I make a comment, Manjuna?
Yes, sir. Please, sir.
Yeah, cyclosporine, there are reports, the cyclosporine in a progressive vitiligo, though very scanty report. In my practice for progressive vitiligo, earlier I used to use oral steroids, and before that I used to use mini-pal steroid. Nowadays I use cyclosporine, and I have been getting, even in children, particularly in children, I must say, and I am getting good result as far as the disease progression halting is concerned. So cyclosporine is a good option for preventing the progress of vitiligo.
Yeah. Janak Thakkar also says it gives good result. Thank you so much for your input. And one very interesting comment here from Dr. Sahana Srihari from Batinda. There have been reports of cyclosporine being beneficial in HIV patient in initial treatment. It reduces the number of infected CD4 cells. A very interesting comment, I think. Yes,
I think it's true for many viral diseases, including hepatitis B, C viruses. Cyclosporine had been used to
Yes.
reduce and so it's not. I mean, it has been also shown in COVID situation also.
Absolutely.
So, but then that is beyond our domain. Our domain, I guess.
Yes. Let me tell you here that we are so much scared of cyclosporine and COVID. So during COVID days, I was reading the literature, and I was very surprised to find that for COVID-induced, cytokine storm and pulmonary, edema, because of that patient dies. There is a recommendation in American Journal of Pulmonology that cyclosporine is the best drug for COVID-induced pneumonia. Because of cytokine storm, the patient dies, and there cyclosporine works best.
I think we have had a good discussion on general aspects of cyclosporine and nicely on psoriasis as well. Now we'll move towards the very important indication, the eczema, the atopic eczema. How long in pediatric? We know that pediatric atopic dermatitis is not an approved indication. Indeed, it's approved for 16 years and above. But still, we use a lot of it. Sandeepan sir, what is your dose and duration of cyclosporine, and what types of atopic dermatitis you use cyclosporine?
Yes. I give cyclosporine to patients during acute flare of atopic dermatitis or very severe dermatitis, which is not being controlled with conventional treatment, and to bring down the quality of life as well as the disease severity. And the usual dose I use is 4 to 5 milligram per kg of body weight. Then, as I told earlier, step down fashion. So this is the dose I use, and I see by and large the result is extremely gratifying for most of the patients. But here I must say, a small fraction of the patient, they do not show that good response. But by and large, most of the patients, I must say more than 90% of the patients show very good result.
Yeah. Rajib sir, how young? Yeah. Yes, Dr. Maitri.
It is actually a question, sir. Sandeepan sir, can you just help me out that chronic lichenified lesions in atopic dermatitis, which drug works the best?
Nothing. There is not a single drug discovered till date which works on chronic lichenified lesions. Actually, there was a lot of hue and cry with a molecule in Germany that is called alitretinoin, that it works on hand and foot dermatitis, hyperkeratotic dermatitis and chronic lichenified atopic dermatitis. But ultimately, it could not, show that good result, and that has been gradually been removed from the market.
Dr. Maitri, sometimes at Apribnust what? You may try that.
Yeah. And yet another interesting comment from Dr. Anupam Das. Cyclosporine inhibits replication of coronavirus as well. So a lot of inputs given by the learned audience. I think we have plenty of things which are. Rajib sir, what is the youngest patient whom you have given cyclosporine? And what do you think the right age to start cyclosporine, especially moderate to severe atopic dermatitis or severe atopic dermatitis?
Well, there is no specific right age to start cyclosporine. The recommendation is from 2 years onwards, but we have in our experience started well below that. I have used up to my lowest age group at which I have used is 1.5 years.
Yeah, I think.
And about the
told
safety profile, the next question that is already there. It is very safe in pediatric age group. The
Yes.
commonest side effect that we encounter in pediatric age group is headache and abdominal pain.
Nothing beyond.
Yeah, renal is the less concern here in adult, especially in
Both renal and
elderly
hypertension.
patient. Yeah,
Where
hypertension
both
is
of
not
them
a
are
major concern.
very rare, very rarely observed.
Can I come here, Dr. Manjunath?
Yes, sir. Yes, sir.
Yeah.
Sandeep, sir.
You know, the issue of giving cyclosporine in pediatric age group, is different altogether. I try to avoid giving cyclosporine to a child below 3 years of age, by and large, unless and until it is extremely necessary. Whenever a child comes to me and I contemplate giving cyclosporine, the first thing I do, I look at the age of the child. The reason being, 80% of the live vaccines are covered by 3 years of age. So the hassle of stopping the live vaccination during cyclosporine therapy and after at least stoppage of cyclosporine for 3 to 4 weeks, that question does not arise. So it is always better to choose a patient accordingly. And this is the only issue which bothers us to give cyclosporine to children below 3 years of age.
I think the one of the question which I was going to ask about vaccination and cyclosporine, you have covered it, and I think you have mentioned a very practical way of handling this. Try to bring up the child until the age of 3 years, and after that, perhaps you can give that issue wouldn't arise. And what monitoring, Raghubir sir, quickly could you tell us about monitoring in a child who is receiving cyclosporine? How is it different than adults?
So than adults.
Yeah.
See, as we have already discussed, the toxicity is far less. So we'll not go in for very close monitoring. What I do in my practice is monthly monitoring the CBC, the urea creatinine, that's all, and the BP. So even the monthly monitoring for lipid profile, serum electrolytes is not necessary in the pediatric patients.
Yeah.
So very baseline monitoring is good enough.
And what topical drugs would work very well with the cyclosporine?
Yeah, I was coming to that because if you go to the literature also and in our practice also, we have seen that the role of topical therapy with cyclosporine combined can significantly bring down the dose of cyclosporine necessary to control the condition. Especially if it's an atopic dermatitis child, proper use of moisturizers, topical tacrolimus, these things, if used with cyclosporine, definitely helps in better disease control. Like in psoriasis also, topical calcipotriol helps or potentiates the use of cyclosporine. So the topical therapy is very important when we are using cyclosporine also.
So which is preferred, sir? Would you use a topical corticosteroid or is it a tacrolimus? Which one is your choice when you are using with cyclosporine?
Yeah, for long term, it's definitely topical tacrolimus. Initially, maybe with topical corticosteroid. Then slowly we can wean off with weekend therapy and maintain with the tacrolimus and the moisturizers, of course. That is how I do it.
Yeah, I think, is there a scope of clubbing yet another systemic drug in a patient who is receiving cyclosporine for atopic dermatitis? Rajiv sir, would you give your input on this? In a pediatric atopic dermatitis, is there a scope of combining yet another drug? Systemic.
There is no point. Absolutely not. There is no point in combining any other systemic drug with cyclosporine for the purpose for which I am giving in atopic dermatitis. Look, the main reason for using cyclosporine in pediatric age group in atopic dermatitis is when the patient is having a severe disease and where they are distressed, where the patient is distressed, cannot sleep, and the parents are distressed. That is why we give cyclosporine.
Yeah, I think, yeah, yes, sir. Please carry on. Yeah.
So if you give a cyclosporine to the full dose, there is no point in adding any other medication with that. And it is also not recommended. There are no reports or no studies, nothing which suggests any other systemic medication that can be combined with cyclosporine in these indications.
Yeah, I think you have wonderfully told. Now, this question definitely goes to Sandeepan sir. If he is not responding to cyclosporine, where does the patient going towards, sir? I'm eager to listen to you. I'm sure what I'm referring to.
Yeah, of course, there are situations where I have given cyclosporine and methotrexate together. because the idea was to stop cyclosporine gradually over next 3 to 4 weeks and continue methotrexate as a maintenance. This I often do in multiple patches of alopecia areata, and this has really worked very well for my patients. Second thing, for atopic dermatitis also, as well as for psoriasis also, I do the same thing. During tapering, I suddenly don't stop cyclosporine and start methotrexate because the disease relapses back very fast. And the patients, all the expectation with a costly drug with cyclosporine, they become little bit, depressed. So it is always a good idea to start both the drugs together and then continue. If the patient is not responding cyclosporine, let me tell you, a small fraction of patient has atopic dermatitis patients have been found that they do not respond to cyclosporine. There you can try methotrexate, and I have seen methotrexate works well in these patients, I must say. Or if the disease is very severe, that the disease cannot be brought under control very fast, it is so severe, and the patient is ready to afford dupilumab, then why not to go to dupilumab for atopic?
Exactly.
Yeah, I think if you are giving a 6 milligram per kg and still not controlled, perhaps there is only one drug to look for is dupilumab. Obviously, but unfortunately, we don't get this drug in India freely. We have to import this drug. But definitely, that's why the patient is going towards. That's for sure. Now I have these two last questions to the youngest among the panel. I'll reserve one to Dr. Abhishek and one to Dr. Maitri. The first question is, we already partly discussed cyclosporine in the current pandemic of corona COVID-19. What's your experience? Are you give like any other patients, the patient who has recently had a COVID, would you still give it or will you defer it for some time? What exactly your take on this?
During the active,
Yeah, please go ahead, Dr. Abhishek.
So basically,
I thought you were the youngest. For that,
nothing like that.
That's a big compliments, Abhishek, for you.
So basically, for the when there is an active sign of infection, for a dermatological active sign in COVID infection, for a dermatological, or the patient has come positive for any other PCR test, for a dermatological indication, I'll not continue cyclosporine. I'll stop it for a couple of weeks. Most of the dermatological condition can wait for that. If the medicine doctors prescribes it, that is entirely different ballgame. But for dermatological indications for atopic dermatitis and psoriasis, that can wait a while. So I'll either active infection or the patient has a PCR positivity, I'll stop it for sure. Otherwise, I do not find any logic to stop cyclosporine treatment or not to start cyclosporine treatment where it is required for dermatological indication, like severe sort of atopic dermatitis or severe sort of this thing, psoriasis. However, there are a lot of patients getting also immunization. This is again a challenge. When to stop and when to restart again. So what I usually follow, I stop at least 1 or 2 weeks before, and at least wait for 2 weeks before restarting the cyclosporine again when the patient has scheduled for a vaccination for COVID program.
Yeah, Dr. Maitri, yes, sir.
Yeah, because this is not a live vaccine, so there is no contraindication as such.
No, sir, it's not there's no contraindication. I want the vaccine to generate the immunogenicity. The problem here is different. I don't expect it can cause any problem. I expect I want the vaccine to generate immunogenicity completely. That's why I'm stopping, not for the live vaccine complication.
That's the only reason why both tofacitinib and cyclosporine, they have been told you may defer it for some time. Just that initial phase of giving vaccine, immunogenicity may be altered because of giving these immunomodulant drugs. That's something.
Purpose of the vaccination can be repeated.
That's true. Dr. Maitri, you have any reservation while vaccinating the patient who is on cyclosporine?
Basically, only maybe 2 to 3 weeks stoppage of medications if the patient is going to take the vaccine. But most of the time, the patient takes the vaccine even without our knowledge. The patient must be on cyclosporine or some other immunomodulator drugs, and he or she must have gone for a COVID vaccine. So, sir, just like Abhishek told, it's just for not affecting the immunogenicity, maybe a 2 to 3 weeks gap.
Yeah, I think we have had a wonderful discussion. The discussion could go on cyclosporine in dermatology because, in fact, I have not touched upon the TN, SJS, alopecia, not much because it's very difficult to cover it in the given schedule. There's a lot of things to learn. I think there has been a lot of learning point. Thank you so much, panelists. You have chipped in all those information, which is very beneficial to me as a moderator and to entire over 70 people, 70 to 80 people, the very selected audience who are invited for this particular webinar. Thank you so much, Sandeepan sir.
Manjunath,
Now
Manjunath,
yes, sir.